arthroscopically. Okay, so we'll go over indications, what the literature tells us about when this might be important. We'll talk about how to do it open, and then talk about decision-making between open and arthroscopic. So indications, the large volume of first-generation PAO surgery really teaches us a lot about what's valuable in the end, and that certainly plays into avoiding FAI after PAO. As we look at the burn data, predictors of poor outcomes, sort of a variety of things, but some of these coming into play. Decreased internal rotation, less than 20, as well as S-tabular retroversion, both driving poor outcomes in the long term. St. Louis experience of John and Perry Schenecker, 10 and 15 years. Concurrent osteoplasty decreased the risk of failure basically 4 times. So those are hips that had poor motion, treated with open osteoplasty, had some of the best outcomes down the road. So the role in PAO outcomes is really probably key. Not all patients need this, but when motion is restricted, it's probably important to maintaining the long-term health of the hip. Interestingly, most of these studies have not found the alpha angle alone to be highly predictive of outcome. So when we think about when we might need this, it's important to think about range of motion relative to the alpha angle. So the dysplastic femur is relatively aspherical. Many have elevations in the alpha angle. Some of them have decreased head-neck offset that isn't captured by the alpha angle. These hips on average have elevated version, so mean about 20 degrees in a large anchor cohort. That means about half of these have femoral version above 20, where even a mild or moderate cam might not really be impinging. And we know from the data from Colorado, IRF is really heavily driven by femoral version and only mildly driven by alpha angles. So this chart on the bottom here shows if you add or subtract a cam, it might make 2 or 3 degrees of difference versus those changes in femoral version drive things 10 or more degrees difference between those groups. Iowa's done great work modeling some of this to look at alpha angles at the 3 o'clock position. This really didn't include a lot on femoral version, and they looked at the dynamics through the walking gait cycle, but these are relatively small numbers. So they had 6 hips with elevated alpha angles that led to these conclusions. So I think it's important to take this kind of data and still extrapolate it to the clinical long-term data that we see. So in my view, we should be thinking about osteoplasty when we have limitations of motion. It's not just going to be the alpha angle. And if we are doing an osteoplasty, we need to even think beyond the alpha angle and think about head neck offset. So we looked at this in St. Louis. Could we identify preoperatively which hips go on to need an osteoplasty based on motion? So over 200 hips during that period, 70% had osteoplasty. And 3 factors come out: internal rotation, femoral version, and then alpha angle. The internal rotation and femoral version are much stronger risk factors for needing the osteoplasty. The charts on the right there show stratified by high alpha angle or low alpha angle. There's actually not huge differences. It's more driven by preoperative motion as well as your femoral version. Certainly your correction probably plays into that, but we were looking here at preoperative factors. So we should be thinking about adding an osteoplasty to avoid post-PAO impingement, and that's going to play into all those factors to maintain, as we talked about earlier, probably at least 20 degrees of motion is a good target. So how to perform open osteoplasty? So the PAO exposure is very conducive to doing this, especially if you get experience with this. This is not a difficult portion of the PAO. So we can get exposure lateral in that lateral window to the rectus. We'll incise the indirect head of the rectus for later repair, shown in that image there. Then with good retraction under the rectus and iliocapsularis and assistance retracting laterally and distally, we can really get exposure broadly to the anterior hip capsule, and then utilize a mostly longitudinal capsulotomy in line with the fibers with small extensions distal and proximal that give you this eye-shaped appearance. And I think with this exposure and experience doing this, you can actually see really well and access cams globally, anteriorly, laterally, wherever you need to be. So this is what this looks like, a quick video looking over someone's shoulder here. So proximals to the upper left, we can see the cam, we can put it through a range of motion, see where these lesions are contacting. Then we can do our resection initially with an osteotome and then complete that eventually with the burr. So similar to arthroscopy, you're moving the hip around in flexion, external rotation to get more anteriorly, coming down into extension, get more laterally. You can really see the vessels very nicely for any lateral-based resections. So here's a case with a lateral component to the cam treated through an open incision without too much difficulty. So why favor open osteoplasty over arthroscopy? So arthroscopy certainly is, the osteoplasty through that approach is familiar to the arthroscopist. It is going to add some time to do it arthroscopically as well as close the capsule after. As we talked about, many of these hips might not need an arthroscopy in the first place, so doing an arthroscopy just for the osteoplasty might not be warranted. This is going to be a preoperative decision, and then you don't get to have that final check of adequate range of motion. On the other hand, open, this is familiar for most open surgeons. It's relatively rapid, maybe 10 minutes or something like that to do it and quickly close the capsule. It's relatively atraumatic as well. You don't have the fluid effects and the potential adhesions that come with arthroscopy with this open approach. And this allows you to really make this decision at the end to kind of leave the OR, ensuring you've got adequate range of motion. So if we put those, I think it really favors open to have the advantages of tailoring this as long as you're comfortable with that approach. So in summary, osteoplasty of the head-neck junction appears to be critical in some hips to optimize the long-term outcome. Open osteoplasty offers adaptability with relatively little downside, I think, in hips that need it after PAO correction. Thank you.
Jeff, how medial or lateral are you making that I-capsulotomy? Are you just taking it straight down from the indirect head, or do you treat it more medial, like under the rectus?
No, I think more in line with the indirect head, and it probably doesn't matter a ton, but it's probably keeping your view most centered like where you are, I guess, and then kind of depending on the mobility of the capsule, how much you need to go medial lateral with your eye extensions is probably tailored in, and how much work you really need to do in a big cam versus some of these mild ones is pretty quick.
I found it's harder to get lateral if you're medial on your capsulotomy than it is to
Yeah,
get medial if you're more
because
lateral.
you're trying to go into extension and that capsule is taut, kind of some of the same things you deal with arthroscopically.
Yep.
That's probably a good tip, that if you know you're going there, to keep that relatively lateral is probably makes it a little easier on you.
Thank you.